Yeah, we are live now.
Good evening, everyone. A warm welcome to our AKSHARAM series. This is the episode 9 of our series, which has been doing very well for the past 9 months since Dr. Vijaya, who is our Oxy president, took over charge. So, this is a combined effort by the Oxy Medical Education Committee and Foxy Medical Education Committee. So, this series has been well appreciated because every topic is thoroughly understood and an expert faculty from across the country or sometimes across the globe also gives us an insight into the topic. So I think it's one of the most appreciated series which we've ever seen. And I thank Vijaya Madam for giving me the opportunity to be the coordinator for this session. Next slide. I request our President Madam, Vijaya Madam. She is a professor at HOD of ESI Medical College, KK Nagar, Chennai, former director of IOG, Madras Medical College, Chennai. Her special interests are high-risk pregnancy, infertility, and laparoscopic surgery. She has a lot of credits and she has got a lot of awards and publications. Madam will be giving the welcome address.
Good evening, everyone, and I have a great pleasure in inviting all the postgraduates and the young consultants for this AKSHARAM series. When I took over as a president last year, and we thought every month we should do one webinar only for teaching purpose. It is not like other webinars where there are panel discussions and other updates. This is one topic will be taken, and from top to bottom, from the basic to the advanced, it will be discussed by only one teacher who is specialized in that. In that way, we are just coming to the 9th class today. Almost 8 classes are over, and all the malignancies, and we have discussed pH, infertility, and now we have come to the most important topic of recurrent pregnancy loss. When I was thinking in my mind whom to call, suddenly Jayanti Madam's name came into my mind. Immediately I searched for your number. Actually, I didn't have your number, Jayanti ma'am. So I just got your number and called, and immediately she accepted. She said, any topic is okay for me. Then we discussed, and we thought RPL will be the most important topic. All the PGs should know, because a lot of controversies are there, and about heparin, about this APLA, and about also about the cervical incompetence. So we thought we will take this topic for this month, and Jayanti ma'am will be introducing Jayanti ma'am now. Yeah, Karpaga. Muted.
Always start with lighting of the lamp in any program and will quickly throw away the darkness. So, Shahidi, music. Next, we'll always pray to Goddess for Saraswati for all for her blessings to make us more knowledgeable, which will help our patients and make us happy. Thank you, Sahiti. Now, Geeta Lakshmi Madam, our Oxy Secretary, and Kiran Pandey Madam also could join. So happy to see you, Madam, to have you
Thank
here.
you, thank you. Sorry, the network issue, little bit of.
Yes. No problem, no problem. Now I introduce Dr. Geeta Lakshmi. Madam is the Secretary of Oxy and Associate Professor at Government RSRM Medical College Hospital, and which is a part of Stanford Medical College. Madam has been a UG and PG teacher for many, many years and member of Chennai Menopause Society, presented papers and posters in various national and international conferences, and has a lot of areas of interest in adolescent health, high-risk pregnancy, and medical education. Geeta Lakshmi Madam will be rendering the Oxy prayer.
Thank you, Dr. Karpagam, for the kind introduction. I welcome Dr. Kiran Pandey, Madam.
Thank you.
Dr. Yes, hello to Vijaya, and I welcome Dr. Jayanti, Madam, and from Guntur Medical College, and Madam is going to speak on recurrent pregnancy loss. Welcome, Madam. And without the blessings of the Almighty, nothing is complete. So we will go on with the Oxy prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, Geeta Lakshmi Madam.
Thank you, Pam.
Now, I welcome Dr. Kiran Pandey, who is the chairman committee of Oxy, for this to be who is the chief guest for this entire series. And I request Vijaya Madam to introduce her, and Madam Kiran Madam will have a welcome speech.
Yeah, good evening, everyone. Good evening, Dr. Kiran, ma'am.
Good
And I'm
evening.
so happy. Almost from the beginning till this 9th series, Kiran ma'am is with us, supporting us. And she's the chairperson of the Foxy Medical Education Committee. And when I was thinking which committee I should join, and I was talking to Kiran ma'am, and Kiran ma'am said this is one of the things where you can teach all the young consultants and postgraduates, and we will also at the same time upgrade our knowledge. That is very, very true, ma'am. I truly realized after this all 9th series, myself, Karpagam and Geeta, we are also learning new points in every webinars. Yes, ma'am. And you all know Kiran ma'am is very, very active Foxian, I should say. And now that the Kanpur conference is also coming, madam is so geared up among this busy schedule. Madam has joined today. It's so great, ma'am. And
Thank you.
she had a lot of research activities and award to her credit, and more than 36 years of teaching experience as a professor and associate professor, and many workshops and many organizing secretary of national conference from basic to advanced, and also now the Indian Menopausal Conference in Kanpur, one of the biggest. We are most of us are joining, few of us are missing also, and we are expecting Kiran ma'am to come for our annual conference in March. Kiran ma'am.
Okay.
Yeah.
Let
ma'am.
me know the detail. I'll see definitely.
Yes, ma'am. Yes, ma'am. Over to you, ma'am. Few words.
I'm going to miss you as a person. Your daughter is probably
Delivering date, ma'am.
delivery data. So I know that is a very, very important thing.
Madam, you are here or you in US?
I'm now in India. I've come back. I also had a granddaughter.
Okay.
So I was there, but now I've come back, and because only actually I have so much of the work was pending, and I was divided into two of the things. Like I wanted to be in US also with my daughter and granddaughter, and had to come here also.
Understandable.
I
Yes,
know.
few words,
That
madam.
is- But anyway, thanks a lot. Wonderful.
Thank you.
This is a wonderful initiative which Dr. Vijaya has taken. And I'm really lucky, I would say, to be part of these all series through since very beginning. And yes, I think the medical education, we are professors, we are like teachers. So we always like those committees and those works where teaching and upgrading of the medical knowledge is important, because every day things are changing. guidelines are changing, the new researchers are coming. So that's very, very important. And Dr. Jayanti, I don't know if she remembers or
Yeah,
not.
madam.
Yeah, I
Madam,
always meet you
I've
into
seen
the Gurukul
Meta.
program also.
Yeah,
I'm
yes.
always there
Yeah,
as a convener of the Gurukul program also, along with Dr. Ashwath.
yes,
So
madam.
there also we meet because you are there almost in all
Yeah,
the
for
teaching
each, I
programs.
have never missed even one session, madam. I was there for
Yeah.
all the sessions.
Yeah, so I also
Madam,
have
but
to
you're
be
a
there
great
during
teacher.
the program.
Yeah.
So, abhi this time, abhi October se after October, abhi November, they didn't had a program.
Yeah,
So otherwise, so I'm always there.
yeah.
And the topic also Dr. Vijaya has selected. She's selecting a very, very good topics, all those which are important for the postgraduates in day-to-day practice as well as for the exam preparation. So they are recurrent pregnancy loss. I mean, what to say of this subject? It is important every day. Even today, unfortunately, that case patient has given me a little bit of I mean, I'm a little sad about it also. She was four abortions were there, and just a minute. Uh, 2 minutes. So, like she had a four recurrent abortions. She was under my treatment. She reached up to 25 weeks. And unfortunately, today she had a PPROM and then she had delivered. Although the baby, we have sent it into, kept it in ICU. I don't know what will be the, I mean, the family, the way every one person of the family looks towards you to do some miracle and save that. It's really matlab like heartbreaking. Sometimes you feel कि what to do. कुछ ऐसा हो कि आप कहीं से लाके डाल दो उसमें. Let's see what happens. I talk to, because this is going to be a very long time. So I talked to the pediatrics head in the medical college, and I've been there associated for such a long time, so they took the baby in an ICU. So it's a very, very important topic, like for day-to-day practice, for the exam, from the point of view of academics. That's very, very important. And the new things, something always to come out. Like now, these days, the immunological factors, the genetic factors on which they are working, maybe something can come out someday and we can be confident and consoling the patient. Yes, we will do something 100%. So that day is awaited. But definitely, I have seen Dr. Jayanti talking very great detail. She covers each and every point. I know. I have been into this Gurukul program so many times. Although all the time one can't be throughout there, like today, you'll have to excuse me from
Yes,
the,
no problem.
because of the conference. The meeting is going on.
Okay.
So, but all the best, and I'm sure the postgraduates will be benefited a lot. That I can assure. Thank you very much. And
Thank you.
Karpa is coming. You are coming and
Yeah,
enjoy
I'm
this.
coming. I'm coming to
And
Kanpur.
what about postgraduates, Joy? Tell them also, motivate
Sure,
them
I'm
for this.
sending the yes.
And Vijay, you have given a very right person. Meera is a gem of a person. She's bringing so many people together,
Yeah,
and the
yes,
good,
man, very enthusiastic. That is
good
why I feel the need.
Chennai team is coming. And Dr.
Yes.
Jayanti, I don't know. I didn't have your number, but I welcome you if you are able to come to IMSCon 2025 to Kanpur. Karpa will give you the details, or other.
And details. Sure, sure.
If you are interested, I mean, I will be very happy personally. Okay. Thank you.
Thank you, Kiran. Yeah.
Please go ahead.
Yeah.
Thank you. Now we'll start on the teaching session. The teaching session for today is recurrent pregnancy loss, one of the most important topics because we see it in day-to-day practice. And our present Madam Vijaya Madam will introduce our teacher, Dr. Jayanti.
Very, very happy to introduce Dr. Jayanti ma'am, and she has got her diploma in diabetic management. She has got a certificate in medical law. She's a professor, Gundur Medical College, and she's the best outgoing student in MBBS. Received gold medal from NTRUHS in MD. Trained in Harvard T2T. Published 10 papers in various journals. Faculty in a state conference and UA Foxy, and member of medical education unit. Member of IEC. Trained in colposcopy and IVF, and more than that, almost all of the PG programs conducted by the Foxy Jayanti madam will be an expert. That is why I just thought madam has to come in at least one of the Aksharam series. I'm so happy. I'm so thankful to Jayanti ma'am. Over to Jayanti ma'am.
Please stop screen sharing, madam.
Yeah, Sahiti.
Thank you, madam, for giving me this opportunity. And thank you, Dr. Vijaya Garu and Dr. Karbagam madam and Kiran Pandey madam for giving and best wishes, and Dr. Geeta madam. So can I start
Yes,
Yes, ma'am.
screen
Yes,
share, madam? Okay. Yeah, is it visible?
Yeah. Is it
yes,
visible? Yeah.
yes, yes.
Okay. So thank you very much for giving me this opportunity to talk a few words and important aspects in recurrent pregnancy loss. Yeah, not able
It is a
to
slideshow. Yeah.
slideshow. Okay, the slide is not moving.
Click the.
So, okay, I'll stop share and share again, madam.
Okay, no problem.
Stop sharing and I'll open the. Yeah, so I'll go through the for a period of 1 hour or 1 hour 10 minutes.
Ma'am, your slides are not seen, ma'am.
Not seen.
Not
yet,
seen?
madam.
No, ma'am.
Okay. Okay, we'll see.
It was seen earlier, madam.
Yeah, I'll go to the Zoom. Okay.
You keep it on desktop, ma'am.
Yeah, it was on the desktop. Is it visible now?
No.
Okay,
No,
I'll go to
ma'am.
the Zoom and share again. Okay.
Yeah, yes, ma'am.
Okay, I'll come back and share it again. No problem.
கனெக்ட் பண்ண பவர் கொஞ்சம் ஃபாஸ்டா இருக்கு போதுமா
Elena.
It was seen earlier, no? It was seen
You were
earlier.
seen, we checked it, madam. We made it full screen also and checked.
No problem. No problem.
Yeah, wait.
Chitra also has it. Sagiti has the
Yeah,
slides.
yes, madam. Yes,
Yes, ma'am.
Okay, let it try. Otherwise, you can project, no?
Yeah.
Ma'am is also not seen. Ma'am.
I think she left and she's joining again because
Karpagam, why not you guide her and the slide share அதை கிளிக் பண்ண சொல்லுமா?
இல்ல கீதா ஏற்கனவே ஸ்லைடே உங்களுக்கு அனுப்பிட்டாங்க அவங்க
yeah,
ஓ
வரதுக்கு முன்னாடி போட்டு
வந்துட்டாங்க மேடம் பார்க்கலாம் இப்போ
Yeah.
சரி சரி ஓகே ஓகே.
I'll slide share again.
எஸ் மேம்.
Okay. Share. Okay.
Your computer screen is visible, madam.
Yeah,
Just
yeah. I'm opening my PPT.
yes
Yeah.
Is it visible?
Yeah, is it
Yes.
visible?
You
Go
can
to
make it.
slideshow and start.
Yeah.
Slideshow. From the beginning you put.
Yeah.
Yeah, good. Correct.
Yes.
Yes.
Now it's visible, ma'am.
Yeah.
Okay.
So, sorry for the inconvenience. So,
No problem.
slowly we go through so recurrent pregnancy loss is an important entity in the obstetrician's practice. So every obstetrician will face at one point of time or other these problems. So we should know what is the recurrent pregnancy loss and how to evaluate and what are the important factors to evaluate and cost effective and evidence based. So this is my present storyline. So for the postgraduate purpose, because this is a postgraduate class, so I need to take a little bit slow and convenience for the postgraduate. So what is miscarriage? A spontaneous loss of pregnancy before the fetus is viable. So the WHO says this is 24 weeks of the gestation. So then what is recurrent pregnancy loss? So there are so many controversies in the recurrent pregnancy loss definition. So, but usually 2 or more pregnancy losses before 24 weeks of the gestation, or 3 or more pregnancy losses as per RCOG up to 24 weeks of the gestation. So, the definition of the loss includes the pregnancy that is confirmed by clinically or by ultrasound. It excludes the molar pregnancy, ectopic pregnancy, and implantation failures. It is recommended to reserve recurrent miscarriage or recurrent pregnancy loss to describe the cases where all the pregnancy losses have been confirmed as a intrauterine miscarriages. So what is the epidemiology? So it is very important to note that 50% of all conceptions fail mostly unrecognized. So 13 to 15% of the recognized pregnancies are lost. So 90% of these losses are before 12 to 14 weeks of the pregnancy. So 10 to 20% have one spontaneous miscarriage. Okay. Successful pregnancy after 2 miscarriages is 80%. So that we should give them reassurance that even after a miscarriage, you can become and mother a child. So what is the incidence of recurrent pregnancy loss? So 1 to 2% of the women experience 2 consecutive pregnancy losses. So 0.4 to 1% have 3 consecutive pregnancy losses. So the risk of miscarriage increases as the number of the pregnancy losses increase. So this is the pictorial. You can see a tip of an iceberg. Above it, you have clinical miscarriage and live births. So more than 50% of the pregnancies after fertilization are lost even before it is clinically identifiable. That is very important. So what are the types of the recurrent pregnancy losses? So all of you know, you have primary RPL, you have a secondary RPL, and now the third one, that is the tertiary RPL, is also definition is being given. So we should discard always the ambiguous terms like blighted ovum, chemical pregnancy, spontaneous abortion, recurrent abortions, or like that. Better to avoid all these terms, use the recurrent pregnancy loss. Okay, so what are the subtypes? So the women may present with different types of clinical scenarios. So all pregnancies are lost. There's no viable pregnancy. You call it as a primary RPL. So a viable pregnancy followed by pregnancy losses. Maybe you call it as a secondary RPL. The pregnancy losses interspersed with viable pregnancies, you call now it as a tertiary RPL. So 3 terms: primary RPL, secondary RPL, and tertiary RPL. But in the exams, usually we talk about the primary and secondary RPL. That is important if you write it as. So what are the risk factors? So once you should remember that the risk factors for a single miscarriage is different and the risk factors for the recurrent miscarriage is a little bit different, almost the same, but a little bit of differences there. So what are the common risk factors for a miscarriage? One is advanced paternal and maternal age. Why? Because there is a decrease in both the number and quality of the gametes. So previous miscarriage. So more than 2 clinically recognizable losses there, this risk is 24%. More than 3 losses, 30%. More than 4 losses, it is 40 to 50%. Smoking, caffeine. So more than 300 milligrams per day, it comes to around 6 or 7 cups of coffee. If anybody takes, it is a stimulant. Obesity, alcohol consumption, and exposure to occupational and environmental factors, pesticides, heavy metals, mercury, and lead. So nowadays we are getting couple and asking, we are living near the area of some places. where we should change the place or somebody, some connections, current places like that. So some of the places where there are factories or this. So sometimes a change of a place also may help them to conceive, especially the net connections, all these places they are asking. So age related. So age related miscarriage, you can see in this. What is the least risk of miscarriage? It is at 20 to 24 years. So nowadays, the educated people are getting married after the age of 25 only. So, but still up to 29, miscarriage risk is 12% only. But as the age increases, you can see after 35 to 39 and after 40, the risk is very high. So, get married and get pregnancy early, at least before 30. Okay, so that it will be beneficial. So, this is the cut it off. Gotcha. So, what is the epidemiological? So, this is the table form. So, advanced maternal age, advancing paternal age, number of previous miscarriages, previous live births, black ethnic background, okay, consanguineous marriage. But it says no increased risk of miscarriage, smoking, alcohol, caffeine. So, either low BMI or high BMI, both are high risk. Chemicals exposure near towers, satellite towers or something. Okay. So now we come to the important points. That is the first trimester etiology for a recurrent pregnancy loss. So the cause of recurrent pregnancy losses are complex and most obscure. Only 50% of the pregnancy losses could be identified. The timing of the recurrent pregnancy loss can offer clues, and in some women, each miscarriage will occur at the same gestational age. So previously, when we are students, we used to have a term called habitual abortions. So all the seniors will know it. So habitual abortions means consecutive pregnancy losses, of course, before the period of viability, and the same etiological factor being operated in each successive abortion. So nowadays, of course, the terminology is not there, but RPL also, just like an habitual abortion. Sometimes each same factor may not operate, but most often the same factor operates. So another important point to remember is 50% of the women will have idiopathic pregnancy losses. Okay, so whatever the investigations you do, you may not get any clue what is the cause for the pregnancy loss. So the important points, causes for the loss. One is the genetic factors, endocrine factors, metabolic causes, immune causes, hyperprolactinemia, acquired and inherited thrombophilias, infections, and unexplained. So this is I hope that all the audience are here. So I want the audience to give an answer. So you have so many causes list in front of your screen. So you can tell me what is the most common cause for the first trimester miscarriages, recurrent pregnancy loss. Suppose for sporadic, what is the cause? For a recurrent pregnancy loss, what is the cause? You can answer in the chat box. I can see. So what is the most common cause of a recurrent pregnancy loss or a sporadic loss? This is the question for audience, and you have 10 seconds time. We'll wait for 10 seconds. We'll see how many of you answer. So all the pages be alert. You can answer. There is more than 55 postgraduates.
They are writing, madam.
Yeah, yeah. So that let them be also alert.
Yes, yes, ma'am. Yes, they are.
Just 10 seconds. We can see we have two. Okay. Okay, we'll see in the chat box. Okay. So unexplained, very good. Genetic, very good. Somebody wrote infections.
Only one person has wrote infection.
Yeah. Okay. So we have so many, so the people are alert.
Yes, madam.
Genetics. So just now I told you the most often it is unexplained. But still, if you leave about the unexplained causes, for sporadic miscarriages, genetic factors are more common. But for recurrent pregnancy loss, immunological factors play an important role rather than the sporadic causes. Okay, why I'm not able to do? Okay. My screen is stuck here. Why? Okay, I'll see. Why every time my screen is getting stuck? Yeah, I came now. So this is the important one which gives the important causes and their percentages. This is an important slide. Please see. You take a little bit time. So genetics only 3 to 5%, anatomical 12 to 16%, endocrine causes 17 to 20%, immunological 20 to 50%, thrombophilias 10 to 20%, antiphospholipid 15%, and lifestyle and inherent defects in the embryo and endometrium. Okay. So this is very important slide. So genetics contribute only 3 to 5%. It may be maternal or it may be fetal. Okay. Okay. Why? Okay. Is it visible?
No, madam.
Not visible?
Not visible.
Not visible?
Not visible. Only
No,
you are
madam,
seeing.
Okay.
The screen
Okay.
shares.
Okay. Is it sharing?
No.
Okay. Okay.
Sharing. Yeah, it's coming.
Now full screen.
Okay.
Slideshow, ma'am.
Okay. We'll see. Okay. Is it visible?
Yes, ma'am.
Yeah. So genetic factors. So repeated first trimester. So is there any clue by taking the history? Can you get any information that this lady has a genetic factor for her recurrent pregnancy loss? So we can have some clue. A repetitive first trimester losses. Usually if you get an ultrasound report that the embryo is an anembryonic pregnancy, there's no embryo, only gestational sac. This may be a recurrent one. It may be a genetic cause. And a history of malformations in the previous babies or mentally retarded babies in the family, or when her age is more than 30 or 35, you can say, then advanced maternal age, you can suspect a genetic etiological factor. So a genetic etiology is less likely with a late first trimester or second trimester losses. So when you get a gestational sac, when you get an embryo, when you get a yolk sac, and fetal heart is there and again disappears, it goes more in favor of causes other than the genetic causes. So genetic causes mostly an embryonic pregnancies, and usually even if there is an embryo, it won't get the fetal heart at all. So that goes in more in favor of genetic factors rather than other causes. And of course, if you have time, if the gestational sac is there, if there is a big yolk sac, if there is disproportionation between the gestational sac and yolk sac, or a large yolk sac, or a small yolk sac, or a calcified yolk sac, or a free floating yolk sac, or a disproportion between the size of the embryo and the sac, this goes more in favor of a genetic losses, and it gives a clue that you may lose this pregnancy even before the embryo gets developed. Very early ultrasound radiological features. Okay. Okay, then we talk a little bit about the chromosomal problems and genetics. So even though the genetic factors contribute to 3 to 5% of the causes, it is very important to know what are the important genetic factors responsible for the pregnancy losses. You have a problem in the number or a problem in the structure. Okay, so problem in the number means it may be aneuploidy or it may be polyploidy. So it may be trisomy and monosomy, triploidy, tetraploidy, polyploidy of the 6 chromosomes are an important numerical chromosomal defects which are responsible for the losses. So structural abnormalities, you have translocations, You have deletions, you have duplications, and you have inversions. So these are the important chromosomal genetic problems. Okay, so chromosomal defects. 70% of the sporadic loss is because of the genetical problems. So most of the chromosomal defects, they lost in the first trimester itself. And 2 to 5% of the recurrent pregnancy loss is because of the genetic problems. Sometimes even if the genetic problems are there, a 0.5% may be live born. So the most important common cause for the sporadic loss is the trisomy 16, that is 30%. But for a recurrent pregnancy loss, the translocations are the most common causes for the miscarriage. Okay, this remember, for sporadic causes, numerical abnormalities. For recurrent pregnancy loss, structural abnormalities like translocations. Okay, so parental. So this is a proven cause of recurrent pregnancy loss. The most common abnormality is a balanced translocation. So a balanced translocation is a rearrangement in the chromosome which breaks into two different chromosomes and pieces are exchanged so that no loss or no gain. So I have put one arrow. So balanced, that is, there is genetic material is not lost or not gained. But a reciprocal means involving the exchange of the genetic material from one chromosome to another. So there's a balanced translocation, unbalanced translocations. There are so many classifications. The point to remember is the parents are apparently normal, but they conceive pregnancies with either normal karyotype or with balanced or unbalanced translocation. Apparently, the couple look normal. The pregnancies with unbalanced translocations, generally they end in miscarriage, but may also result in stillbirth or live birth with congenital abnormalities. So despite the increased risk, the most couple can have a healthy live birth. So embryo. So the wife is normal, the husband is normal, but sometimes the embryo is abnormal due to abnormalities in the egg, sperm, or both. The most common is monosomy or trisomies. So endocrine and metabolic factors. So all of you know, India is the capital of diabetes. So we are seeing, especially now, if you get 10 pregnant ladies, one or two, one will be the diabetic one, the other will be a pre-diabetic. So a poorly controlled diabetes, increased levels of blood sugar and HbA1c levels in the first trimesters increases the risk of loss. The miscarriage risk increases with the level of the HbA1c. So now we have an audience question. Suppose if you have a HbA1c of 11, what advice you give to your patient? You please write in the chat box. So is my question, I hope my question is audible. Suppose if you have a lady whose HbA1c is 11, what advice you give to the couple? Okay. So we're getting good answers.
Yes,
Somebody
madam.
wrote genetics. No. Okay.
Oh my God.
Okay.
Alert, very alert.
Yeah. So HbA1c more than 10 carries increased risk of anomalies. Very good. Counsel her about the risk of congenital anomalies. Somebody wrote MTP, some termination of pregnancy as malformation risk. Yes, very good. We are getting good number of the answers. So one thing is you counsel her and inform her that the chances of structural and congenital anomalies are more. So you can offer a medical termination of the pregnancy if HbA1c levels are very high, but you should not force her to get her aborted. You just explain to her what is the risk, and if she want to continue, you have to continue the care of a diabetes, but you can offer an MTP when HbA1c level is very high because of the risk of congenital anomalies. So one question here is, what is the risk of chromosomal abnormalities in diabetes complicating pregnancy? Because it is not the chromosomal problems that is responsible for the miscarriage. It is the structural abnormalities are responsible for the recurrent pregnancy loss. Okay. So now coming to the important problem. So we are getting so many cases of thyroid problems. So presence of you have of course, we discuss about the treatment a little bit later. So presence of thyroid autoantibodies and untreated hypothyroidism both are risk factors for the recurrent pregnancy loss. The luteal phase defect. There is inadequate growth and function of the corpus luteum, which is essential for the maintenance of the pregnancy during first 7 to 9 weeks. So may be responsible, but the RCOG latest says that the luteal phase defect may not be that much evidence based to say that it is responsible for the recurrent pregnancy loss. So polycystic ovarian syndrome, the exact mechanism is not known. The increased risk may be due to insulin resistance, hyperinsulinemia, hyperandrogenemia, and hyperhomocystinemia. So now we come to the fascinating topic, that is autoimmune directed to self, SLE, and antiphospholipid syndrome. So the autoimmune is the antibodies are directed, alloimmune is directed to foreign tissue or cells, an immune response to placental and fetal antigens. Maternal immune system mounts an immune response for the spontaneous abortion. Of course, miscarriage occurs. So SLE, the risk of loss is 20%, mostly in the second and third trimester of the pregnancy associated with antibodies. So now all of you know what is antiphospholipid antibody syndrome. Okay. So you have primary APA and secondary APA. Primary APA means without any underlying immunological disorder. But if SLE is associated with antiphospholipid antibodies, it is called secondary APA. So all of you know the most treatable cause of RPL, which is well accepted and evidence-based. Up to 15% of women with recurrent pregnancy loss have antiphospholipid antibodies. So there are so many, n number of the antibodies against phospholipids like phosphatidylserine, ethanolamine, NXN. So many antibodies are there, but 3 antibodies are important and is responsible for the recurrent pregnancy loss and adverse pregnancy events are lupus anticoagulant, anticardiolipin antibodies, and anti-beta 2 glycoprotein 1. So, what is the mechanism of action? Why there is a miscarriage in APS? So, inhibition of trophoblast proliferation. In vitro evidence says that these antibodies, they act against the phosphatidylserine and inhibits the formation of syncytial trophoblast. The syncytialization is required for proper placental function and spiral arteries and placental villus thrombosis. So the antibodies against phospholipids increase the thromboxane and decrease the prostacyclin synthesis with the placental vessels, which results in vascular constriction and platelet adhesion and infarction. Then the fourth mechanism is the activation of the complement pathway. Okay. So inhibition of trophoblast proliferation, improper syncytialization, spiral arteries and placental villus thrombosis, and complement pathway activation is at the maternal and fetal interface, resulting in local inflammatory response is the points necessary for the abnormal growth of the embryo. Okay. So the association of these antibodies with the thrombotic complications is termed APS. You have a pregnancy problems like spontaneous miscarriage, stillbirth, intrauterine fetal death, and preeclampsia. So this is the picture. You can go through the picture. So NXN5 anticoagulant disruption, increased trophoblast apoptosis, trophoblast cell differentiation, so complement activation. So all these are responsible for the recurrent pregnancy loss, preeclampsia, IUGR, and intrauterine fetal death. Okay, so all of you are familiar. I think all the postgraduates are very much familiar with the APS criteria, but we go through the recent Sydney criteria, which was published in the recent journal. So the Sydney criteria, you have vascular thrombosis, you have pregnancy morbidity, we have a laboratory criteria, we have subclassification according to the antiphospholipid positivity. So pregnancy morbidity, all of you know, more than one morphologically normal fetal loss, more than 10th week of gestation, or presence of preeclampsia, eclampsia, severe pieces, unexplained losses. So many things are there, pregnancy morbidity. You have a laboratory criteria. So lupus anticoagulant present in plasma for more than 2 occasions. So subclassification, this you can go through. Subclassification includes type 1. So more than one laboratory criteria is present, any combination of the 3 antibodies. Type 2A, lupus anticoagulant only. 2B, anti-cardiolipin antibodies only. 2C, anti-beta-2 glycoprotein 1 antibody only. Okay. So lupus anticoagulant presence itself is enough. That means it is present or absent. But for anti-cardiolipin and anti-beta-2 glycoprotein, you have a levels. So 40 MPL or GPL units. Okay. So here is just I want to put one question for the postgraduate. So all of you know that an antiphospholipid antibody syndrome, there is one criterion called these laboratory criteria should be positive at least in 2 samples 12 weeks apart. So just I want to ask you a question that why that 12 weeks apart was kept? So can anybody answer? You can put it in the chat box. Why 2 samples should be positive for the antibodies and why the criteria of 12 weeks gap was taken? Okay, you can write in the chat box. I'm not getting any answers.
Madam, as the lecture goes, questions are complicated, I think, for them.
No, madam. So simple. So
Yes,
okay.
they started answering.
Yeah, okay. So one thing is 12 weeks gap is taken because some of the viral infections, they cause false positive test and these antibodies will become positive. So that if there is any fever like hemorrhagic fevers, dengue fevers and listeriosis and some of the infections, they create a condition that these antibodies, they cross react with the lupus anticoagulant ACL. So once the fever subsides, these antibodies will fall down so that the exact level will be identified after 12 weeks. So that 12 weeks period is taken. So this is favorite question for most of the examiners. That is why I'm giving them so that they can answer better in the exams. So hyperprolactinemia. So why hyperprolactinemia? There are 3 ways. The ovulatory dysfunction, HPO axis alteration, there's impaired folliculogenesis, oocyte maturation, and associated luteal phase dysfunction. A dopamine agonist may improve the outcome. So hematological disorders. So everyone is very favorite. What are the inherited thrombophilias? So factor V Leiden mutation, deficiencies of protein C, protein S, and antithrombin 3, hyperhomocystinemia, and prothrombin gene mutation. Okay, infections. No infectious agent has been proven to cause recurrent pregnancy loss. So previously we used to do torch test for all the patients, but nowadays torch test is not recommended and of course, they are associated with spontaneous loss. It is only sporadic for that pregnancy only, not for the recurrence. So bacterial vaginosis is a risk factor for a sporadic loss, not for a recurrent pregnancy loss. Okay, so now we come to the management of the first trimester losses. So the management include evaluation and also the treatment. Okay. So when to investigate? Ideally after 3 losses, but clinicians are justified in starting investigations following 2 pregnancy losses only. But we get the patients where they pressurize the doctors to get evaluated even after 1 pregnancy loss also. But you can start earlier investigations considered in special cases like an advanced maternal age, bad obstetric history, medical disorders, history of infertility, a known family history, and a patient's request due to social reasons also, you can start evaluating the recurrent pregnancy loss. So what to be taken? A thorough, important history, a good history will give a clue most often the cause for the recurrent pregnancy loss. So gestational age at which the previous pregnancy loss has occurred, the specificities of the each pregnancy, whether it is an embryonic pregnancy or an anembryonic pregnancy, or a fetal heart appeared and disappeared, or fetal heart not appeared at all. So all these you have to take into consideration. Is there any associated pain? Is there any uterine instrumentation? Because the uterine instrumentation may cause infection. And history of venous and arterial thrombosis, so especially post-abortal thrombosis, we have now in our labor room, we have a case where she had a previous 6th-month abortion, 6th-month miscarriage. In the post-abortal period, she developed a deep vein thrombosis, and she was on anticoagulants. Now she's pregnant with 35 weeks of the pregnancy, and we are planning for her termination because she started developing preeclampsia now. So we stopped using warfarin, we have switched over to heparin, and we are planning for the delivery. So you have to ask the history of diabetes and thyroid dysfunction. So family history is very important. You have to ask the history of recurrent pregnancy losses and any children with mental retardation or any children born with the genetic defects which was already identified. Okay. So what investigations are mandatory? So we have a complete blood count, blood sugars, fasting or HbA1c, TSH, thyroid autoantibodies, antiphospholipid antibodies, and a transvaginal 3D ultrasonography. Optional investigations are if you suspect any problem with the shape of the uterus or interior of the uterus, go for a sonohysterography, hysteroscopy. First, you order for a 3D ultrasound. A 3D ultrasound will give a most often the clue regarding the uterus. So, a sonohysterography or hysteroscopy. So, inherited thrombophilia screen only if there is a personal or a family history of thrombosis. Prolactin, history of amenorrhea or oligomenorrhea, go for the prolactin. A genetics testing of the pregnancy tissue, RS-CGH, a parental genetic analysis, a sperm fragmentation test. Men with unhealthy lifestyles, you go for a DNA fragmentation test and presence of anti-nuclear antibodies. Okay. So everybody is very interested to know about what are the genetic tests available and what should be offered to your patient. So you have two samples. One is the sample of the products of conception, and you have the couple, that is the want to be the parents. So a products of conception should be sent for a genetic analysis after 2 pregnancy losses. So what we send routinely is the chromosomal microarray, because the chromosomal microarray is very important, and it gives a good results with the non-live tissue also in a miscarriage also. Parents, you offer a karyotyping, but in case of if necessary, you go for the whole exome sequencing and whole genome sequencing also, but these are very costly. QF-PCR, FISH and CMA and RS-CGH also are there, but we routinely send for chromosomal microarray, but the RCOG and AKSHARAM recommends array-CGH, array comparative genomic hybridization and next generation sequencing, because the most of the deletions, inversions, and small copy number losses or gains are identified by the next generation sequencing and RS-CGH. So for a chromosomal microarray, for a products of conception, so you have to send the sample in the normal saline, or if the culture medium is available, you can put it in the culture and send it. Now, don't add formalin. If you add formalin, you will lose the report. That is very important. Okay, what are the tests that are not recommended by the recent guidelines? So, torch test is not recommended. Anti-HLA antibodies are not recommended. NK cells not recommended. So, cytokine, LH, testosterone, homocysteine, vitamin D, luteal phase, these are all not recommended by all the organizations. So, important to remember, the recurrent pregnancy loss represents a psychological trauma. The fear of results of next pregnancy lead to psychological problems. So, one of the most accepted treatment is TLC, that is tender loving care. Okay, the AKSHARAM recommends to talk with the patient. This is very important. A clear and sensitive language, and honesty, shared planning, a supportive care in the next pregnancies, kindness, recognition of the patient as an individual, time for questions, a good listening, respect, and clear and sensitive language. So the point that I liked is use the terms like baby, fetus, pregnancy, like that. Do not use the terms like products of conception, blighted ovum, like that. So the patient will be happy to listen these words rather than the technical terms. So, a chromosomal anomalies, all coupled with the result of abnormal fetal or parental karyotype, should receive genetic counseling. So, translocations are counseled for pre-implantation genetic diagnosis. If the defect is paternal, artificial insemination by the donor is maybe you can give an idea. For maternal defect, donor egg may be fertilized by the husband's sperm. So this is the evaluation chart. If there is a one miscarriage, you can ask her to go for another pregnancy and try another pregnancy. If there is a second miscarriage, you have to send the samples for products of conception for the genetic analysis. If there is an aneuploidy, it may be a sporadic one. They can go for another pregnancy and try. If it is a euploid, the pregnancy losses may be because of the other causes, not because of the genetic problems. If the POC of chromosomal microarray gives an unbalanced translocation, you have to ask for the parental karyotyping. If the parental karyotype does not give a clue, and if you have a strong suspicion, you can order for a whole exome sequencing or next generation sequencing, but these two are costly tests. So then we come to the endocrine dysfunction. So overt hypothyroidism should be treated with thyroxine, hyperprolactemia with bromocriptine and cabergoline. So control of diabetes with the drugs and everything can give a good results. So a word about thrombophilia. For a woman with hereditary thrombophilia, and anti-thrombotic prophylaxis is usually not suggested unless in the context of the research or if it is otherwise indicated for a thromboembolism prevention. It's not routinely needed. Okay, then we come to the important point. Okay, Okay, so this is the antiphospholipid antibody syndrome is an important one which can be treated and we can get a good results. A low dose aspirin started before conception. So the recent X-ray shows that the low dose aspirin should be started before conception. An unfractionated heparin, 5,000 to 10,000 units 12th hourly. So alternative, you can go for an unfractionated or low molecular weight heparin. The prophylactic dose of heparin should be started at the date of the positive pregnancy test. Okay. So important to remember is aspirin, unfractionated heparin, and low molecular weight heparin. So, okay, infections. The common ones are chlamydia, urea plasma, urea lyticum, and chronic endometritis. So for chronic endometritis, you give doxycycline. Okay. So all are very fascinated about immunotherapy for recurrent pregnancy loss. So what are the immunotherapies available? We have hydroxychloroquine, we have steroids, we have IVIG. So, but this immunotherapy is not recommended as per the routine AKSHARAM and RPL guidelines for the routine recurrent pregnancy losses. So hydroxychloroquine, by the opinion of the rheumatologist, if the antibodies are positive, if the rheumatologist advise, then only we have to offer the hydroxychloroquine. If it is started, it is a safe drug in pregnancy. It can be continued throughout the pregnancy and each case should be individualized. Not that you put a chloroquine. So IVIG. So it is not routinely recommended. But when do you give? When there are more than 4 recurrent miscarriages. If you think that it is because of the antibodies only, you can give the IVIG. But it is not a routine. So male factor. In the male factor, look for the lifestyle problems like smoking, alcohol consumption, exercise, body weight. So DNA fragmentation test is only for the explanatory purpose. It's not a routine test. Sperm selection is not recommended. Antioxidants not shown to improve the chance of live birth. Okay, then what to offer? What is unexplained RPL? Even after all the investigations, if you could not find out any cause for her pregnancy loss, then you call it as an unexplained recurrent pregnancy loss. So all these are not recommended. You see, lymphocyte immunization therapy, IVIG, steroids, heparin, low-dose aspirin, progesterone, intralipids, endometrial scratch, GCF. So all these are not recommended for so don't get confused. For unexplained RPL. So when you want to give, each case should be individualized. Okay. So this is an important trial, that is a PROMISE trial. Okay, it says that there is a moderate benefit of giving vaginal micronized progesterone 400 mg twice daily. Okay. So what therapeutic interventions could be offered to all couple? So you can see in the bottom, doing nothing is an option. Okay, if you asks about multivitamin, you can supplement multivitamins because they're safe in the pregnancy. And the last is that doing nothing is an option, but we don't do because we try to give some treatment. But if it is unexplained, better doing nothing is an option. Okay, so these are all the tests by RCOG, but some of these are modified in the recent AKSHARAM guidelines. This is the flow chart. Okay, this is the latest AKSHARAM guidelines. So pictorial summary of the diagnostic test. They have given recommended tests are lupus anticoagulant, anticardiolipin antibodies, thyroid abnormalities, and 3D ultrasound scan for the uterine abnormalities, and a genetic test, immunological test, sperm DNA fragmentation are not recommended. Screen for hereditary thrombophilia is not recommended. Genetic tests are not routinely recommended. Okay. Okay. So the overall risk of recurrent miscarriage is about 25 to 30%, irrespective of the number of the previous spontaneous miscarriages. The chances of successful pregnancy is 70 to 80%. Reassurance and tender loving care is very much helpful. So this I have asked already audience questions. So now we have finished almost the first trimester miscarriages. So then we go to the important another one, that is the second trimester miscarriages. So a second trimester miscarriage. So previously I told you that the timing of the miscarriage will give an important clue for the cause of the recurrent pregnancy loss. Okay, so we have important causes like cervical insufficiency, uterine abnormalities, intrauterine synechiae. You have the infections like bacterial vaginosis, and you have thrombophilias. Okay, so okay. Cervical insufficiency. So what is cervical insufficiency? Inability of the cervix to retain a pregnancy till term in the absence of uterine contractions. It presents as an acute painless dilatation of the cervix. So what we routinely tell to the patients, painless dilatation of the cervix, expulsion of the rupture of the membranes followed by expulsion of the baby live abortus. Okay, this what we routinely tell to the undergraduates. So what is cervical insufficiency? So what are the causes for the cervical insufficiency? Some of the Mullerian anomalies like bicornuate uterus, septate uterus, unicornuate uterus may be associated with cervical insufficiency. A DES exposure in utero, an abnormal collagen tissue problems like Ehlers-Danlos syndrome and Marfan syndrome, and an isolated developmental weakness of the cervix. So acquired causes are forcible mechanical dilatation of the cervix beyond number 13 dilator, cervical lacerations and tears, cervical conization and cauterization or LEAP procedures, amputation of a part of a cervix or a Fothergill's operation. So these are the causes for the cervical insufficiency. So diagnosis is usually made in different settings. So when a patient presents with acutely, how she presents, sudden onset of the white discharge. If you put a speculum, you see the cervical os is dilated and membranes are bulging out. And then a woman may present with a history of previous second trimester losses consistent with the diagnosis of cervical insufficiency. Or you have sent her for routine ultrasonography and you have seen that the cervix is dilated. Okay, so acute presentation usually between 18 to 22 weeks, with pelvic pressure or a rectal pressure of recent onset, there is an increased mucous vaginal discharge and there are no contractions. So what is the history-based? Women gives history of previous painless cervical dilatation treated with circlage sometimes in the second trimester of a previous pregnancy, or a history of ruptured membranes without contractions in the second trimester of the pregnancy. So this is the recent RCOG says. So, and suppose you have a pregnant lady whom you want to do surveillance for a cervical length. Okay. So routinely, so this is an audience question. Routinely, at what gestational age you order for a ultrasound for a cervical length? First, earliest gestational. So what is the, so my question is, what is the earliest gestational age at which you look for the cervical length? So you can write in the chat box, what is the earliest? Okay, 14 weeks, 11 to 13, 12, 14, 13, so many. Okay. So usually we don't do it in the first trimester. We start at the, as per the recommendation, it is 12 to, not at 12, sorry, 14 to 24 weeks. You do the ultrasound surveillance. But, okay. What are the high risk conditions and intermediate risk conditions where the surveillance is once in 15 days is necessary to identify the cervical length and shortening? So this is previous preterm labor, previous premature rupture of pre-PROM, second trimester losses, previous cerclage, a known uterine abnormality, when there are intrauterine adhesions are there and treated and patient becomes pregnant, history of trachelectomy. The intermediate risk includes history of previous full dilatation seizure, a ledge when the depth is more than 1 centimeter, when there are more than one procedure on the cervix, and when there is a cone biopsy. Okay, so ultrasound diagnosis, cervical length 2.5 cent, less than 2.5 centimeters, internal loss more than 0.8, and there's a bulging and funneling of the membranes into internal loss. So you have this picture, all of you know, T, Y, V, U. Okay, so this is an ultrasound picture of T, Y, V, U, all of you know. So normal cervical length at 14 weeks is 30 to 40 mm. The normal internal loss diameter is less than 8 mm. The cervical index, the funnel length plus 1 by endocervical length. Normal index is 0.32. Anything more than 0.52 or above is indicative of cervical insufficiency. Okay. So interconceptional period. Passage of number 8 Hagar's dilator beyond the internal loss without any resistance or pain, and absence of internal loss snap on withdrawal in the premenstrual period. So easy to remember. Number 8 Hagar's dilator, Foley's catheter number 16, bulb filled with 2 ml of the normal saline, or passage of a uterine sound without any resistance is diagnostic of cervical insufficiency. So 8 Hagar's dilator. So old books say number 8 Hagar's dilator, number 14 Pratt's dilator, pediatric Foley's catheter filled with 2 ml of the bulb. So evidence, how you put the evidence? A Foley's catheter bulb filled with a radio opaque dye inserted into uterine cavity, and you take an X-ray. If the catheter bulb is seen lying in the endocervical canal with a small little pull, you can say that cervix is not sufficient. So if the cervical insufficiency is identified, what to offer? So you can offer a drugs like natural mechanized progesterone, you can offer a pesary like Arabian pesary, or you can offer a cerclage. So usually the first option is the cerclage, but if the patient doesn't agree, you can offer the pesary and drugs. So, okay, what are the names? Just for the PG's theory purpose, I have written so many names. You can just remember it, write it in your theory, but we do not routinely practice all these procedures. You have a transvaginal cerclage, McDonald cerclage, Shirotka cerclage, worm stitch. You have a lash procedure. can be done ultrasound guided. You have an abdominal cerclage like Benson and Durfee, Novi, Maharan areas, and you can do it laparoscopically also. During pregnancy and interpregnancy period also, you can do a laparoscopic cervical cerclage. Okay, so surgical treatment is Shirotkar's operation, you have a McDonald's operation, you have a Worms operation, and you have an abdominal cerclage. Madam, is the time is there? Can I go little slow or can I do it fastly?
Yeah, no, you can take your time, ma'am. No problem at all. It's
Yeah,
only
another 20 minutes I can
Yeah,
tell?
no problem. Yeah, of course.
Okay. Okay. So what is the principle of the cerclage? So a non-absorbable encircling suture is placed around the cervix at the level of the internal os. It operates by interfering with the uterine polarity and adjacent lower uterine segment being taken up. Okay. So uterine angle and polarity is changed and the lower uterine segment taken up is prevented. So timing of the operation. Elective cerclage. In proven cases, around 11 to 14 weeks or 2 weeks earlier to the lowest period of the previous loss, as early as 10th week, but not before 10th week. Why? Why not early? This is because the causes for the first trimester loss are different and causes for the second trimester loss are different. And by 10 weeks, if the embryo is healthy, only it will reach up to 10 weeks. If the embryo is not healthy, it will not reach up to 10th week. Okay. So that is important. That is an elective operation. What is emergency cerclage? When the cervix is dilated, when the membranes are bulging, when you see a patient came with history of excessive mucoid discharge, you put a speculum, you see a cervix which is dilated and when membranes are coming out, you may think of putting an emergency cerclage. Okay. So, but before putting a cerclage, always confirm a live fetus with no anomalies prior to cerclage and treat the infection prior and avoid coitus before putting a cerclage. So, by this, it is important to note that it is always better to put a cerclage after NT scan, after 12 weeks, because it will give a little bit of reassurance that the baby is almost healthy because you did a double marker by the time an NT scan is completed. Most of the abnormalities are ruled out and target 9 anomalies are also ruled out. And important is chromosomal defects are also 90% ruled out. So it is always better to do a cerclage after NT scan. Okay, this we talk about the little bit about the what the RCOG recommendation says. So history indicated cerclage. So history indicated means you put a speculum, the cervix is normal. Ultrasound also, it may give a normal cervix. But if the history says 3 or more preterm births, or if the history says 3 or more second trimester losses, so even though apparently it looks normal, you can offer a history indicated cerclage. Okay. So it's a painless dilatation, painless rupture of the membranes, prior cervical surgery. So if these are there, so this is a general practice point, good practice point. So if the history is unknown, if specific characteristics of previous adverse event are helpful, like a painless dilatation, rupture of membranes, and prior cervical surgery, you can offer a cerclage. Okay. So when do you go for an ultrasound indicated cerclage? Okay. So you can see what is the recommendation. So suppose if you have a women who have a single pregnancy, there are no other risk factors for preterm birth. Cerclage is not recommended when the cervix you see incidentally identified short cervix. Okay. On a late second trimester scan. But it is B recommendation strength only. So what is grade A recommendation? If the cervix is 25 millimeters or less at the gestation less than 24 weeks, or instead of that, with the repeated scans, when the cervix is getting shorter and shorter, you have to be very careful. Okay. Then the another important point that was given is an ultrasound indicated cerclage is not recommended for funneling of the cervix. So dilatation of the internal os and ultrasound in the absence of cervical shortening. Okay. Okay, history of. So when you see an ultrasound serial monitoring, when you see the cervix is getting shortened, when the cervical length is less than 25 mm, may benefit from an ultrasound indicated cerclage. So this picture shows the Arabian pessary. So this is how to put the Arabian pessary in place. So this is the picture shows, okay, how to apply tight positioning, incorrect positioning, everything. So this is the trial going on for an Arabian pessary to prevent preterm birth in twin pregnancies with short cervix. So the results are being awaited. So, okay. So now we talked about the vaginal cerclage. So when do you apply a trans-abdominal cerclage? So in a woman with previous unsuccessful transvaginal cerclage, you can consider a transabdominal cerclage. See, this transabdominal cerclage can be done in the pregnancy or can be done in the preconceptional period also. So you can apply a transabdominal cerclage in case of previous failed vaginal cerclages or previous cervix previous because of the previous delivery when the cervix is so lacerated that you cannot put a stitch, or when the cervix is so short that you cannot apply a stitch, also you can consider a transabdominal cerclage. The RCOG says previous unsuccessful transvaginal cerclages, you have to apply an abdominal cerclage. So a laparoscopic and open cerclage also have a similar efficacy, but laparoscopic approach is associated with less complications, but a more expertise is needed. But a transabdominal cerclage can be applied even when the patient is not pregnant, when the preconception period also. That is important. So what is rescue cerclage? So now the term rescue cerclage is changed to emergency cerclage. So emergency means when the patient came with a little bit of dilatation, bulging membranes, and you put a speculum, you see the membranes, then you order for an emergency cerclage. So before putting an emergency cerclage, see that there are no uterine contractions. So uterine quiescence should be there, infection should be treated. You can go for an emergency cerclage. So emergency cerclage may delay the birth by approximately 34 days in suitable cases. Okay. But advanced dilatation more than 4 centimeters and the membranes prolapse beyond the external os, they are associated with high chances of cerclage failure. And at the same time, you may rupture the membranes and she may land in a rupture of membranes case and she may get infected. Okay. So rescue cerclage, always the dilatation points, remember, is that there should not be any uterine contractions. There is no excessive bleeding and uterus should be quiescent, and the maximum upper limit will be only 27 weeks 6/7 before 28, of course 27 6/7 days. And advanced dilatation is a contraindication when the membranes prolapse beyond the external os. If you put a cerclage, you may rupture the membranes. Okay. So, okay. So what are the contraindications for a cerclage? So the active preterm labor, clinical evidence of infection, continuing vaginal bleed, preterm premature rupture of membranes, when there is a fetal compromise, a lethal fetal problem, or the fetus is dead inside, don't go for a cervical cerclage operation. So a little bit about the cerclage operations and varieties. Transvaginal cerclage, you have McDonald's, Shirotkar's operation, abdominal cerclage, and an occlusion cerclage. So any cerclage above the Meccan rod ligaments is the high cerclage. Below the Meccan rod ligaments is the low cerclage. So Meccan rod is not a high cerclage operation. So you can see Meccan rod's lowest, next to Shirotkar's, next is the transabdominal cerclage. So this is the picture. So this one is the Shirotka cerclage. We open the posterior POD and anteriorly and we close it. Okay, this is the lash procedure. Of course, we are not doing it in any way. So this is the McDonald cerclage and this is the worm's stitch. The right one is the worm's stitch and laparoscopic. So this is we have one or more audience question. What is the ideal suture material for a cerclage operation and which suture material you use in your institution? So you take just 20 seconds time and write your answers. What is the ideal suture material for cerclage and what suture material do you use in your institution? Black silk, somebody wrote black silk, proline, marceline tape, proline. Okay. Okay. So ideal suture material is marceline tape, but anything non-absorbable you can consider. Okay. Oh. Share చేయనా ఇక్కడ ఉన్నా పాస్ ఏం చేయాలి చూడు అన్ని షేర్ పెట్టినా yeah why it is passed.
Ma'am, double click on the slide, ma'am.
Okay. Stop sharing. Okay, I'll sharing again. No problem. Yeah, it is shared. Okay. Okay. So now we come to important. So marceline tape. So marceline tape is the ideal suture material. So whenever I go and click another one, I'm getting my screen is getting stuck there. Okay. I'll complete it.
It's
Okay.
slideshow.
Okay. So what are the complications? Am I visible? My slide is visible?
Visible.
Okay. So complications are slipping or cutting of the suture, chorioamnionitis, infection, rupture of membranes, abortion, and preterm labor. Just here I wanted to tell you one point that if the os is open, it is 2 centimeters dilated. If the membranes are at the external os, how do you apply the cervical stitch? That is important because the points to remember is total you take her to the theater and you do it under good anesthesia and ask the deep head down position and take a sponge holder and put a small gauze piece or a little bit of wet cotton and push the membranes slowly through the sponge holder into this and put a stitch and remove the sponge holder. Or you can put a Foley's catheter, inflate slowly at the external os and slowly inflate it and put the Foley's catheter inside, stitch it and take out the Foley's catheter with a bulb inflated with 5 to 10 ml of the fluid basing on your clinical situation. Okay, this is important. Okay. So this post-operative care, AKSHARAM and recent guidelines says there's no need for the sedation, no need for bed rest, no need for antibiotic coverage. It case to be individualized. Tocilite is not necessary. Progesterone supplementation is also not necessary. But the standard textbook says all these things. Better to give. Okay. So when to remove the stitch? At 36 to 37 weeks, you have to remove the stitch. If it is a Shirotka stitch or a high cerclage, you need to do it under anesthesia. If not removed in time, if the patient goes into labor, there are chances of uterine rupture or a bucket handle tear of the cervix or a cervical tears. So with the floating head, there are chances of cord prolapse. The patient usually goes into labor quickly and delivers vaginally. Okay. So then coming to the vaginal pessary. Vaginal pessary is effective, inexpensive, easy. It alters the cervical anal axis and displaces the weight of the baby away from the cervix posteriorly. Can be inserted at 12 to 14 weeks and removed at 37 weeks. Should be removed weekly for cleaning and size adjustment. So, okay, then we quickly go through the other factors, uterine factors. So, 6 to 7%. So, mostly reduced intrauterine volume and poor vascular supply are responsible for the uterine factors for recurrent pregnancy loss. So, septate uterus 65%, unicornuate 50%, didelphus 40%, bicornuate. Okay. So, acquired are fibroids, uterine leiomyoma, intrauterine adhesions, and incompetent cervix. So, uterus should be assessed with saline infusion sonography, HSG, or a hysteroscopy. A saline infusion sonography is more accurate than a HSG. Okay. So, 3D ultrasound. If you have a facility for 3D ultrasound, it is the best method to identify and evaluate the uterine anomalies. Okay. MRI differentiate a septum from a bicornuate uterus. So, unicornuate uterus. So, why there is miscarriage in unicornuate uterus? Because the volume is small. Okay. So, but the evidence says that you need not do. No surgical procedure can enlarge the unicornuate uterus. So, doing nothing, waiting. Some cases you can apply with a cervical cerclage, but it should be reserved for those cases with previous losses. Okay. Septate uterus. This is the most common developmental anomaly. The poorest outcome. The mechanism is not clearly understood. The main important is implantation on a poorly vascularized septum. So, AKSHARAM 2023 guidelines do not recommend the hysteroscopic resection of the septum, but the RCOG says that you can individualize the case provided that if you think that if by doing a septal resection, you may improve the capacity of the uterus, you can try for a hysteroscopic resection of the septum, but each case should be individualized. Okay, bicornuate uterus. So, usually we don't do anything with for the bicornuate uterus. It is considered unnecessary and is best reserved for well-established otherwise unexplained losses. But this is not, of course, this for the PGs I have written, the surgeries, the Strassman's abdominal metroplasty or laparoscopic metroplasty, but we do not recommend it for a patient or a woman suffering with RPL. Okay. So didelphus, the best good outcome. The only surgery indicated is the removal of an obstructing longitudinal vaginal septum. Okay. Okay, congenital anomalies of the uterine arteries was mentioned because of the alteration in the blood flow to the developing blastocyst and implanted blastocyst and placenta. Okay, so leiomyoma. Previously, we used to think that these submucous fibroids, bigger fibroids, are responsible for the recurrent pregnancy losses because of the improper implantation of the trophoblast and the placenta. But the recent X-ray says that no need. So large submucosal fibroids distort the cavity and occupy a large area. But surgery is not indicated when the myomas do not distort the uterine cavity and when symptoms are not attributable to them. But hysteroscopic, abdominal, whatever the myomectomy, it is not recommended by AKSHARAM recent guidelines 2023 for a case of recurrent pregnancy loss. Not for, do not get confused, not for infertility and not for other causes. Symptomatic, asymptomatic. So if you want to do, you can remove if she is having heavy menstrual bleeding. For a recurrent pregnancy loss, the removal of a myoma is not indicated. But they have written another guideline that individualization of the each case is very important because each case is different. If you think that she may get benefit from a removal of a myoma, you can. But it is not for recommended as per the AKSHARAM. Okay, intrauterine sine K. Okay. Okay. So intrauterine sine K, excessive curettage for the pregnancy problems. There is an insufficient endometrium to support the fetoplacental growth. There is may present with hypomenorrhea and amenorrhea. Okay, diagnosis is high index of suspicion, scanty bleeding. We do a hysteroscopic removal of the adhesions and we put an intrauterine balloon catheter after adhesiolysis and we give her antibiotics, NSAIDs and estrogen for 4 weeks after the surgery to encourage reepithelialization and last week we give progesterone for a withdrawal. So we had to prevent the recurrence. So Asherman's, the cause is suspicion, hysteroscopy, adhesiolysis, antibiotics, putting a balloon catheter, antibiotics, estrogen treatment, and progesterone in the last week. Okay. So this is almost covered. The pregnancy is a hypercoagulable state. A woman with heritable or acquired thrombophilic disorders are significantly at increased risk of pregnancy loss. So this is also covered. Activated protein C, protein S, antithrombin 3. So just a little bit of audience question. What is the most common inherited thrombophilia? What is the most thrombotic one among all these? What is the, so two questions. What is the most common one? What is most thrombogenic one? What is most common? So, okay, we'll see for 10 seconds. So always, okay, only one person answered. We'll see. 2.
Protein C in the
Okay. So the most common is paclitaxel mutation, but most thrombogenic is antithrombin 3. Okay. Okay. So this is all you can go through. So what is the mechanism of action? There is thrombosis on the maternal side of the placenta. Okay, but the relationship is less clear with the recurrent pregnancy loss. The treatment, of course, we have already discussed lodosasprin and heparin, either unfractionated or low molecular weight heparin. So what about bacterial vaginosis? The bacterial vaginosis in the first trimester is reported as a risk factor for the second trimester miscarriage or a preterm delivery. We have to treat with oral clindamycin, significantly reduces the incidence of miscarriage and preterm birth in general population. But the RCOG says that it is the relationship is sporadic. It is not associated with recurrent pregnancy loss. Okay. So the bacterial vaginosis is the risk is with that pregnancy only, not with the RPL. Okay. So this is also almost finished, but for completion's sake, what are the endocrine factors responsible for the RPL? Thyroid, diabetes, PCO, luteal phase problems, hyperprolactinemia, and diminished ovarian reserve. Thus, we go through quickly. So hypothyroidism, isolated as well as recurrent pregnancy loss. There is increased risk of spontaneous miscarriage. Okay, this point I want to tell you here is, suppose if you have a TSH normal but anti-TPO positive, do you give L-troxin or not? So the TSH within normal range, when the thyroid antibodies are positive, recent guidelines say that there is no need to treat. Okay. Okay, this is the recommendation. There is no association between the subclinical hypothyroidism and RPL. An association may coexist between the consecutive RPL and subclinical hypothyroidism. with anti-TPO antibodies. Okay. So it is associated with sporadic miscarriages. So based on the TSH levels above the pregnancy specific range or above 4 milli-international units, then only you treat subclinical hypothyroidism. So, okay, hyperprolactinemia, why it is associated with miscarriage? It's associated with ovulatory dysfunction, alteration in HPO axis, impaired folliculogenesis, oocyte maturation, or luteal dysfunction. Bromocriptine is the treatment of choice. So, diabetes we have discussed already. So, well controlled, there is no increased risk. So, PCO, metformin treatment can reduce the risk of miscarriages in PCOS. So, luteal phase deficiency. So previously we used to dump all the pregnant ladies with the progesterone therapy. Okay. So gold standard diagnosis is for endometrial biopsy, luteal phase deficiency, but we are not doing a mid-luteal progesterone. We will do an abnormally short luteal phase, less than 13 days. Detected by an interval from the mid-cycle LH surge to the menses is an objective and reliable diagnostic criteria for luteal phase deficiency. Okay. So, okay. There is a more LH is there. This high LH affects on the developing oocyte. There is desynchronous maturation is responsible for the recurrent miscarriage. So, okay. So this is the recommendation. So natural micronized progesterone is the drug of choice. You can go for dihydrogesterone also 10 milligrams BD, but the main recommendation is when you have a history of recurrent pregnancy loss, she presents with bleeding, you give 400 milligrams natural micronized progesterone BD up to 16 weeks. There is only history of recurrent pregnancy loss. There is no bleeding. You give her 200 milligrams up to 12 weeks of the gestation. So this diminished ovarian reserve. Okay, this is all these tests are not recommended as by the latest guidelines. So infections, no infectious agent is proven to cause the recurrent pregnancy loss. Okay. So the important point that is gaining more attention nowadays is the chronic endometritis. That is up to 56% of the, so this is vice versa. A chronic endometritis patients may have 56% pregnancy loss. Not RPL 56 is chronic endometritis. Okay. So how do you diagnose chronic endometritis? Presence of histologically documented plasma cells in the endometrial biopsy with immunohistochemistry, CD138 staining is positive, you can say it is a chronic endometritis. Okay. So if you identify an organism, it is better to do a culture and give the antibiotics. So this is all we have dealt already. We finish it. There's no need to repeat. So if untreated, okay. So important antibodies are anti-thyroid antibodies, anti-sperm antibodies, anti-trophoblast antibodies, and blocking antibody deficiency. So this we finished, I think. So this is also not necessary. So this is so much of mechanism. So when to start treatment? Preferably preconceptionally, you start aspirin, or when the pregnancy is attempted or documented, and heparin is started as soon as the urine pregnancy test is positive. Okay. So LMWH is better than unfractionated heparin. Okay. Not as less incidence of thrombocytopenia. Heparin induced thrombocytopenia. Okay. We'll finish it 5 minutes, madam. Okay. Is it?
No problem. No
Okay.
problem, Jayanti. Take it.
Take it. Oh, it is 7:44. Okay, we'll finish it.
Wait, yeah.
Okay, this is an important slide. An unfractionated heparin, 5,000 units subcutaneously BT with prior thrombosis 10,000. Of course, you can go for enoxaparin or dalteparin. Okay. So most of the therapies proposed immune-mediated recurrent pregnancy loss are harmful and must be considered experimental. So this just
That
to
previous
quickly go.
slide, that heparin slide, just put no.
Okay,
Heparin.
okay.
Yeah.
Okay.
Any
So
change in that?
yeah. This is with the symptoms without prior of course the same, madam. A dose
Okay.
can be adjusted depending upon the weight of the patient. So it is easy to understand. That's why I kept this. So for
Okay.
with prior thrombosis, without prior thrombosis, with prior thrombosis, 1 milligram per kg body weight. Okay. So normal delivery, it is better to start within 6 hours. But cesarean section, they say 12 hours, but we are starting after 24 hours.
Yeah.
We are worried. So what routinely you use, madam, either enoxaparin or dalteparin? What is the
Enoxaparin.
Enoxaparin. We are also using enoxaparin. So this is all so much fascinating therapies and treatments given, which were most often not recommended by the ASHRAE and ASRM, whatever the guidelines. So, but just for completion's sake, so immunostimulating therapies, leukocyte immunization, this is also not recommended. So suppressive therapies are not recommended nowadays. Okay, IVIG. So IVIG, we don't have any experience. We have experience of IVIG with ITP with very low levels of the platelets. We have given few cases for this IVIG. For abortions, we didn't use any IVIG at all. But what is the recommendation is, ASHRAE says it's not recommended, but the RCOG says if you have more than 4 miscarriages in the early pregnancy, you can try an intravenous immunoglobulin very early in the pregnancy. But otherwise, it is usually not recommended. Okay. So the only indication is more than 4 consecutive pregnancy losses in the early pregnancy. It should not be of genetic cause. Without any genetic cause, you can give IVIG. So progesterone. So what is the action of progesterone? Not only like luteal phase deficiency, this is important. It has got a known immunosuppressive properties. It inhibits TH1 and shift from TH1 to TH2 and successful and more favorable outcomes. Okay, but ASHRAE and everyone recommends only vaginal administration, but not either IM administration. Okay, not oral or IM, only vaginal administration. They increase the local and intrauterine concentration of the progesterone better than a systemic administration. So if there is a bleeding, go for 400 mg BD. If there's no bleeding, go for 200 mg BD. So intralipids, not recommended. So peripheral NK cell activity, endometrial NK cell activity, all this, of course, it is not recommended now. TNF alpha inhibition not recommended. So this slide just we go through and we finish off. So immunosuppressive therapy, we had a good experience with hydroxychloroquine 200 milligrams BD. Few cases where there are recurrent miscarriages, where there is a documented evidence of antibodies in the patient. I mean, whatever the immunological, either it may be SLE, it may be scleroderma, it may be PSS, or it may be lupus antigen, whatever the antibody test is positive. We have concerned with the rheumatologist. A few cases we have given a hydroxychloroquine. She was on the hydroxychloroquine even prior to the pregnancy also and continued throughout the pregnancy. And we had a live birth after 4 miscarriages for one lady and after 2 miscarriages in another pregnant lady. So the male factors, why blaming only the lady for the miscarriage? So the equal contribution by the males also nowadays, even 30 to 40% of the cause for the recurrent miscarriages. If you evaluate carefully, even the male factor is also at fault. So the recommended only test for the male partner in the couple is karyotype, but you should look into the lifestyle problems like smoking, alcoholism, diabetes, thyroid, in the husband also. So in recurrent pregnancy loss, there is increased incidence of Y chromosome microdeletions in partners of a fertile compared to fertile and infertile couple. We have in miscarriages, they see Y chromosome microdeletions. So increased incidence of sperm chromosomal aneuploidy, particularly sex chromosomal disomy when compared to the fertile women. Okay. So specialized testing is not routinely recommended, but in few cases you can go for an advanced sperm functioning test like hypoosmotic swelling test, acrosomal status, nuclear chromatin decondensation, increased DFA, and lipid peroxidation when compared to men in some cases. So another important point to remember is a, a paternal carrier of MTHFR C677T mutation and hyperhomocystinemia were associated with DNA damage and recurrent pregnancy loss. So this is the final slide, which, so you can say whenever there are two RPLs, go for the POC products. If it is a euploid, it is not the genetic cause. If it is aneuploidy, she can try for another pregnancy. If it is an unbalanced translocation, go for the parental karyotyping and offer a PGT for the future conceptions. So these are all the factors: endocrine problems, uterine problems, vitamin D deficiency, hereditary thrombophilias, and APS. So all these are, so many causes are there. So all these should be evaluated properly and try to find a cause in the case and treat it according to the evidence-based treatment. Not all the tests are necessary for all the patients. Choose the test which is necessary appropriately and which is cost effective in your patient. Okay. So euploid, if you send the POC for chromosomal microarray, it is also costly. It takes around 10,000 rupees for a chromosomal microarray. But if it is definitely more than 2 RPLs, you have to send it for chromosomal microarray or array CGH or next generation sequencing, whatever the facility is available. So in summary, you have so many causes: genetic, uterine, immunological, endocrine, lifestyle, all these are there. Okay. So RPL is not a single disease. Multiple causative factors are there. A proper evaluation is necessary. An appropriate care is important for the good outcome. The not recommended treatment should not be offered to your patient. And tender loving care is very, very important for the prognosis. Okay, this is the tender loving care. These are the important trials which PGs has to remember. So a PROMISE trial, that is progesterone in RPL, a PRISM trial, also progesterone, a tablet study. So RPL and euthyroid with anti-TPO antibodies, T4 life study, STAR, single embryo transfer of euploid embryo, CERM, chronic endometritis and RPL study, STOP-IT trial, so Arabian pesary in case of short cervix. So these are the important trials which you have to remember, and you may get a question in the fourth paper sometimes. So finally, so remember this slide. This is the master slide. So all the conditions, treat appropriately, and finally tender loving care is very, very important. What the SJ says is show a little empathy and communicate to the patient very empathetically so that it will be useful for the patient. So thank you, Madam Vijaya Madam, and thank you, Karbaka Madam, for giving an opportunity to talk in this session, Madam.
Thank you, Jayanti. Maybe they will post some questions in the chat box if they are there. But
Okay.
anyway, I just want to ask you about the role of steroids.
Yeah. So routinely, we don't give steroids as per the guidelines. Usually, the steroids are not recommended for preventing recurrent pregnancy loss, madam. But in individualized cases, when she's already using prednisolone for an immunosuppressive therapy, better. But steroid embryopathy is also there. Some of the side effects on the fetus is also there. If can she avoid a steroid therapy and continue the pregnancy, she can. Otherwise, each case should be individualized, and you try to manage with the lowest dose of the steroid, which she can have a comfortable, like rheumatoid arthritis with patient is on steroids and some other problems, already known immunological problems. Recently, the rheumatologists are giving information that the lowest dose which you can continue steroids, but it is for the RPL, it is not recommended.
Recommended as such. What about vitamin D? There was one slide
Yeah,
where
yeah. So recently, so much of articles are there on the role of the vitamin D. Vitamin D is a good antioxidant and immunomodulatory effects, and it improves the quality of the oocyte and in males also. So vitamin D deficiency, especially very important in infertility also. So the only test that we routinely recommend is the vitamin D assay that as the infertility specialist, and we also do routinely is the vitamin D. So few persons says that why wasting so much of time on vitamin D? You can give vitamin D because most of the Indians are vitamin D deficient. So because of the immunomodulatory properties, because of the antioxidant properties, it improves the quality of the oocyte. And in males also, it is very important to look for the vitamin D and supplement vitamin D for a better quality of the oocyte and sperm.
the dose has changed recently. That vitamin D, earlier they were telling weekly for 6 weeks and then monthly for 6
8
months.
weeks, routinely we give 8 weeks,
But
madam.
now they are telling every month like that for 12 months like that. They are
Yeah,
coming.
depending on if it is not, she or he is not deficient, we can
Should
give a
be enough for
prophylactic
8
dose.
weeks.
If it is deficiency is there, we have to supplement weekly.
There's one question in the
If the
chat
levels
box.
are not there, if you are not able to do the vitamin D levels essay, you can give once in a month. Hypervitaminosis is also dangerous, madam.
I know that.
Yeah.
Karpagam, there is a question in the chat box.
Yeah, I'm just there, madam. So basically, probiotics, there's a huge thing about
Yeah.
What
Probiotics, probiotics for recurrent pregnancy loss. Actually, the infections and this bacterial vaginosis and premature prom, all these are associated with infections. So probiotics usually they prevent the vaginal infections and premature. So probiotic role is so much controversial in RPL, in preventing RPL. But if you say preterm labor, premature rupture of the membranes, and prevention of bacterial vaginosis, so if you give, some of the studies have giving probiotics throughout the pregnancy to prevent premature rupture of membranes and prevention of bacterial vaginosis and preterm labor. But for RPL, the probiotics are not recommended. But if the patient is having a bacterial vaginosis, previously suffering with bacterial vaginosis and now also having the symptoms like a creamy white discharge, a foul smelling discharge, and you have sent a vaginal swab and it turned out to be a positive for bacterial vaginosis, you can give probiotics when that individual case. It's not routinely recommended for the prevention of the recurrent pregnancy loss. So it does not come under recommendations actually. But for preterm, they wanted to include, but
About
not
the
at
period
included.
of viability, what is your take on the period of viability? Is
So
it
period
22
of
weeks or 20?
viability, textbook says it's 24 weeks, but in our setup, even 28 also, it is a little bit difficult. But nowadays, with the good advent of the good neonatal facilities in our facility in our place, which is a little bit of in between town and city, mega city, we salvaged in the private setup, we salvaged the even 26 weeks to 27, 28 also.
Yeah.
But not everyone, but few cases are salvaged, but not before 26.
No, the miscarriage, when we say the miscarriage, should we
Yeah,
say
it is the period of viability.
up to 20 weeks or 24?
24. WHO and all the recommendations says 24.
24 weeks, yeah.
India also, Foxy and Indian government also says we are along with the other international on par, because we have seen the baby of 26 weeks baby live and 3 years old now.
I know.
Yeah, I have delivered the lowermost, I mean, 10 years of period of infertility with pre-PROM. At 25 weeks, I continued the pregnancy for 2 more weeks. At 27 weeks, 3 days, I did cesarean section. And that baby is now 3 years old. So
Okay.
26 also in our places, we could able to survive.
Yes. Yes.
Madam,
But not
Jayanti
all the
Madam,
cases. Hmm.
Jayanti Madam,
Madam
this is
Geeta Lakshmi.
Dr. Geeta Lakshmi, and
Madam.
it was an excellent lecture on RPL, Madam, because
Madam, it is,
I saw
I
many
think
of.
it is too prolonged, madam. I tried to
No,
make
no,
it
no,
so
no.
simple, but uh,
You know why? Because most of the PGs who have joined today are the exam going PGs who have done
yeah.
the theory and they are waiting for the practical exam.
Okay, okay.
So,
Madam.
whomsoever is going to get a case of RPL, definitely they are going to be benefited because it was such a wonderful lecture, madam. Really very useful, and I think the PGs will be benefited. But one question to you, madam.
Madam.
You are talking about vitamin D, no?
Yeah.
So empirically, you put on vitamin D without testing the vitamin D levels, is it?
No, madam.
Ah,
Actually, they're supposed to test vitamin D. If it is
okay,
deficient, you give therapeutic dose. That is weekly once for 8 weeks.
okay.
But we have questions that it is costly and most of the people may not afford.
Yes.
So that is why if they are not affordable,
Okay.
there's nothing wrong in putting vitamin D at least 4 doses. In that
Okay.
case, we don't give too much of heavy dose like 8 tablets or 10 tablets.
Yeah.
We give 4 tablets weekly once and then
So,
stop.
so in your practice, you are
Yeah, yeah.
using.
In our practice, if she is affordable, if she comes with infertility or a recurrent pregnancy loss, we ask her to get it done.
Okay, madam. Okay.
If she's
Yeah.
poor and
One more
she
question
cannot
is there,
afford.
Jayanti. Karpakam.
Madam.
Madam, I lost my connection. I'm not able to get the
No,
question.
there was an indication for enoxaparin.
Enoxaparin. What
Should
is, yeah, there
APLA
are.
screening be done in pregnancy? 2 questions, madam.
Madam, I'm not
In
able to get it.
indications for enoxaparin.
Yeah. So
And the second question is, should APLA screening done in pregnancy?
So for a normal routine pregnancy, we don't do an
It's not
aplastic.
as
When she presents with a recurrent pregnancy or when she had a history suggestive of antiphospholipid
Criteria.
syndrome
Yeah.
like thrombosis. So recently we have just now I told you we had a case of post-abortal DVT on day 10. Now she is pregnant, 9th month pregnancy. Like that, if she had a case of history suggestive of thrombosis, previous history suggestive of thrombosis, previous history of stroke because of the thrombotic episode, or previous history of libido reticularis, all these thrombotic events, and she presents with other I already known and identified case of antiphospholipid antibodies, or if she had a recurrent pregnancy loss, or if she had early preeclampsia, some other indications, we go for an antiphospholipid antibody screening, a recurrent one. So if the patient insists, I already told, if the patient insists, or if her age is more than 35 years, or if the family insists, or if she is financially strong enough to undergo test, you can offer a test even after one miscarriage also. There's nothing wrong. If the patient insists, you can. But after 2 miscarriages, you have to offer because these tests are there. So you have to offer all these tests. So if the patient is able to financially bear and she is interested to know her status of antibody status, you can offer an APLA testing. But in the APLA testing also a good laboratory and which is, which is validated, that is important. And another, if you think about the antibodies, a lupus anticoagulant, the presence itself is necessary. There's no need to go for the titers or anything.
Yeah.
But for the others, definitely you need the units, either 40 GPL units or MPL units. Okay. So that is important.
Yeah. Yes,
They
madam.
have
One more.
listened so very carefully, Polarkla. They were asking very, very difficult questions. Does the
Yeah.
APLA results vary in pregnant and non-pregnant status?
Status.
So usually the results does not vary because these antibodies are there even before pregnancy also. So usually it doesn't vary. But if she had a history of fever, so avoid doing an APLA testing when the patient has history of fever or history of any other surgery, any of the stressors, or usually dengue fevers or unexplained fevers or some long-term antibiotics. In that case, better to take a gap of or in the post-abortal period or in the post-delivery period if you want to do it after 6 weeks.
Yeah.
Yeah, I think we are done with the questions.
Yeah.
Very,
Thank
very nice presentation, Jayanti. It was really
Thank
good
you.
to have a full revision of the RPL from the first trimester and the second trimester, and also the trials and also the RCOG guidelines and SHA guidelines. What more PGs are need no? Everything is there.
I think
So very, very nice. I'm so happy that we thoroughly enjoyed your lecture and hope to see you often, say in
Thank you.
Proxy soon.
Thank you, sir. Thank you, madam. It was actually
Yes,
a
madam.
very
We will be inviting you for the annual conference, madam. Jayanti, madam.
Thank you. Thank you,
So
madam.
it is on the March 8th and 9th.
Okay,
So
madam. Thank you. Thank you.
please block your dates. Okay, ma'am.
Okay, madam. Okay, madam. Thank
Thank
you.
you so much, madam. Excellent
Thank
talk.
you very much. Thank you, madam.
Yes.
Thank you
Thank you,
for
madam.
all
It was
the.
more of a marathon session, but definitely
Yeah.
no point or nothing was left behind. Everything was
Yes.
covered from top A to Z. So if it makes us feel that you have learned a topic thoroughly, so that you have an overview of the whole causes, the management, and how to counsel the patients. And finally, always when it comes to RPL, we are more affectionate with this tender loving care. We tell them,
Yeah.
reassure them that,
Yeah.
if there is a cause, I think we'll treat the
Yeah.
cause.
Yeah.
Even if there is no cause, still there is a good chance of having a healthy,
Yeah.
happy
Definitely.
baby ready.
Definitely.
The usual thanks.
Thank you.
Karpaga?
Yeah, I know. I just like
Thank
to
you.
give a vote of thanks. I
Okay.
thank our President Vijaya Madam for this excellent series, because a lot of people keep calling me and asking me when are you when is the next session, and can we have a compilation of the entire series? We'll update them soon regarding that. And secondly, our Secretary Madam Geeta Lakshmi Madam for all the support we have been receiving, and every time Dr. Kiran Pandey Madam, she never, not even wherever she is, whether it's traveling or in America, she just joins from wherever she is. And I thank Jayanti Madam for being an excellent faculty this time. I'm sure all the PGs, we also learned a lot about all the latest
Yes.
advancements, all the trials, everything that need to be known for recurrent pregnancy loss. And also, last but not least, with Shahiti and the Sheep platform, who have been been very helpful and giving us this
And
online
also
platform.
taking good photos every session.
Yes, good photos and technical help.
Yeah.
And I always available for technical help all the time. So Sahiti is so approachable and so friendly. And whenever I sent Shahiti's number to Madam, and Madam shared her PPT in case there's a problem with her sharing. So thank you so much, and wish you all a very, very happy new year. And we will continue this session. We really would like to continue, because once a month this teaching session has been really become passionate for us.
Thank you.
Thank you.
Thank you,
Happy
madam.
New Year.
Happy New Year, madam. Happy New
Happy
Year.
New Year and Sankranti wishes.
Thank
Thank
you.
you, ma'am. Thank you.
Thank you.
Thank you,
Wish you the
madam.
same. Thank you.
Bye.
Thank you.
Bye, Geeta.
Thank you.
Bye, bye, Vijaya.